2, right? It's kind of a trick question because we haven't really talked about it yet. We talked about this, more of a reminder that your plain film x-rays, each image individually is a 2-dimensional image. Your brain is going to want to make it, try to put it 3-dimensional, but it is not. It is only 2-dimensional. You have no depth on any particular single x-ray image, none whatsoever. So what do we do if we need more? Well, we talked about those orthogonal views yesterday, but in reality what this is leading into is a CT scan, which we're going to talk about today, and kind of how that works and how that develops more detailed imaging. Because of something like this, right? We all know this is a bad day. Probably got in a fight over dollar tacos in the south side of San Antonio, right? That's my guess. But, because it's definitely not like a normal, like, I'm out to attack somebody knife. That's like a kitchen knife.
That looks like a big Texas Roadhouse.
Texas Roadhouse knife? Maybe they ran out of reds. Right? This guy lost his mind, so sure, we're doing what we need to do. But right, what good is an x-ray gonna do for me here? Right? Probably not a whole lot. I know where the knife's at, but what I don't know is what did it affect on the inside, right? And some of the x-rays we looked at, it's very generalized, very basic, right? It doesn't really map out a lot of the organs really well. It doesn't show the detail that I need. And so this guy would end up getting a CT scan, and that's kind of what we're gonna talk about today. CT, mammo, MRI, the basics, what are the machines, how do they work, and kind of when do we use them, pros, cons, all of that stuff. Because again, arming you guys with the knowledge of the pros and cons of each of the modalities, okay, is gonna help you understand what to order when it's time. I had a good question come up yesterday after class, talking about particularly MRI and ultrasound. And they were like, hey, this is radiology. I thought those don't do radiation. That is accurate, they do not, and we'll get to that, right? It's still lumped under radiology because it's an old school colloquialism term. It always used to be, just go to the radiology department. In reality, in today's day and age, they're starting to lump this together and they call it a diagnostic imaging department, which all this stuff falls into. That's what we're doing. We're doing imaging to diagnose something, so it's diagnostic imaging. But back when this stuff first created, and if you still go to clinics, you still see radiology, like over the top of a lot of the check-in desks and things like that. That's not just radiation studies, it's all of these diagnostic imagings. So, all right. So here are some CT images for you. I do not expect you to read these yet, right? At the end of block 2 for sure. If you were to get something like this, you would get a Bucker factor going, okay, there's something major going on here. What's going on, right? Well, that's going to depend on your patient's symptoms and your patient history, okay? This particular case is a post, I think it's post, or acute read it, right around that aspect of COVID patient. So this is what COVID did to somebody's lungs. So just from generalities right now, I will tell you, all of the bright white in the lungs is bad news, right? Fluid, it could be fluid, it could be collapsing of lung tissue, but all of this is inflammation, damage from COVID, and a COVID pneumonia. I don't remember if this is an acute phase or if this was the symptoms have gone away and this was like afterwards because they were still having symptoms if they got the scan. But either way, just look at the amount of detail we can see on this compared to the couple of chest x-rays we saw yesterday. Wasn't tons of detail in there, it was a good generalized study, but this really gives you a whole lot more detail. We will get into that when it's time, but just gives you an idea of like when I need that higher detailed study to be able to diagnose what I'm looking for, my concerns, why a CT comes into play. That's everything we're gonna cover. So CT started about the early 1970s. It started with cross-sectional images of the brain, okay? That's what that picture is over here. This is one of the very first CT image studies. Look at how pixelated and grainy it is. You can't really make out a whole lot, but there wasn't enough to be able to determine if there were brain bleeds. It's one of the biggest things we use CT for is brain bleeds and head trauma, and that's where it first started. And so that's kind of the initial of it. The people that kind of came up with it, Hounsfield and Cormack, right? So they got the Nobel Prize for this because of the fact of the advancements in medicine, right? And to the point where there is something that we'll talk about briefly on CTs to where you can measure the density of something on a CT with your little screen, like not you guys here in this course where you're out in practice. You can put a little circle on there and we'll talk about different densities and highlight it, and it will tell you the density of something. So you can look and go, is that blood, is that fluid, is that tissue, what is that density? Because of how detailed the CT is, and those are called Hounsfield units. So you did get something named after him for coming up with this, and it's measuring the density of the different tissues on a CT. A really way that's commonly used is sometimes on a CT you'll see a mass, and you're like, I don't really know, is that a cyst, is that something else? If you don't give contrast, it can be hard to tell. Well, you can put that little marker over there, and cysts are usually filled with some type of water or water-based substance, and masses are more tissue. So you can do that to determine just by looking at it going, is that probably a cyst, or is that probably a mass that needs further evaluation just by the density. Morphines too, you'll see that when you get into your radiology rotation, or like your internal medicine, or maybe even ER when you're ordering these studies. But it's a really cool tool to kind of help you evaluate these guys. That's what it looks like. I have another slide. We call it the donut of truth. Because you can't hide anything from a CT scanner, right? It's really hard to hide. What do you notice about this particular machine? Right? What type of patients a lot of times, when you, maybe, and for those that have been in the medical field, that you go to want to get a CT or an MRI on, they're like, oh, I can't do that because I have what? Claustrophobia, right? More of an MRI issue, not a CT issue. It is open. They are very rarely inside of this thing unless you're doing a head CT, and even then we're talking seconds. These scans happen in less than a minute, and some of them less than 30 seconds once they hit the button and start. It's very quick. The way it's set up is on the inside of this donut here, okay? They're circular, there's a bunch of sensors, right? So before we talked about x-ray, one radiation source, patient, one plate behind to read that imaging, right? What this has is multiple sensors on the inside, and it varies by the quality of the CT scanner, 4, 16, 64 slice, you don't need to worry about all that. But the better they are, the more sensors they have. And each sensor has its own radiation source directly across from it, right? And so what's happening is this thing revs up and starts spinning like this, and then it starts spitting out the radiation, hitting the patient from all different angles, getting it on all different sensors from the different angles, and then the machine puts those things together. I'm gonna date myself here, right? Has anybody ever seen the original Gene Wilder, Willy Wonka? Yes? No? Okay, good. So for those that haven't, right, the kids go through the little factory and most of them disappear. They don't have to listen, right? But there's one kid in particular who's obsessed with TV. And so what they do is they put it in, and he goes in and he zaps himself, and he's up above their head like a million different pieces, and it gets put back together again. That's what this thing does with all the different images it's taking. So just think of it as a more advanced x-ray with a bunch of smaller images, and then the computer puts it together for you to give you what the CT scan is. And that's why it's more detailed. Here's some of the images that it can produce. We'll get to a slideshow or a slide where it talks about the different planes, but you will have to know kind of what planes and what we're looking at from all these different views, right? But we got the head CT up there, so that's going to be an axial slice. We look at how nice we can see the brain tissue. I can't necessarily make out gray and white matter very well, and that's okay. But when we get to the head CT portion, you will be able to pull out bleeds, and that's the biggest thing, is being able to pull out acute bleeds for when you're doing trauma. This here is an abdominal CT, okay? And so look at how nice, this is with contrast, look at how nice the liver stands out, spleen, right? Liver and spleen. Can't really see the kidneys that well here yet. I got some bladder down here, and we'll see some better organs and better pictures of that, so you can see how much more detailed that is. So you can imagine if I had a knife going into the torso there, I can actually take a look and see, did that miss the liver, did it hit the liver, then what are we dealing with here? Here we have a knee CT. Now we just talked about how x-ray for the most part is our musculoskeletal stuff, which is accurate, but sometimes in the area of major fractures, right, this can be really good for when they're gonna go into surgery and fix this. See how detailed is that fracture, what is exactly involved. A lot of times ortho is going to want that prior to them going in and doing surgery, so they have an idea what they're dealing with. The one up here, the scanner doesn't necessarily make, What this is a lot of the newer scanners have the ability to do what's called a 3D reconstruction. So it takes all the images from that knee one below, and it puts it together, and freshman said, oh yeah, and it puts it together as if it was one of those skeleton models over there. So you can actually rotate it, turn it around, kind of see what's going on. It's not gonna be super beneficial from a diagnosis standpoint. Not really gonna help you guys out in any way, shape, or form for the most part, but it can be helpful in sometimes surgical cases or things along those lines, so to put it together in that aspect. But the machine just does a different setting, so it scans this, and then the provider asks for the 3D reconstruction, and all they gotta do is go in and hit a couple of buttons, and it just does it for them. So, you will not be really reusing this for any type of diagnosis. It's not useful for that. There's your same YouTube video that I can't show you in this classroom. It works in other classrooms, but it shows you kind of what I explained in a little bit more detail. A couple-minute video of how the CT scanner actually works. More images. What do we think? I don't like the color of it. It's just how the image came. What do we think the darkish gray arrow is pointing to? Right, a sternal fracture. Right? So let me circle it up here. Even though it's a big arrow. So, there, right? My sternum should be coming straight down like this, but it doesn't. It shifts over. Okay? And then also, this one does come straight down. It's a different patient. But when I look right here, I got that break in the cortex, and we're gonna go over the cortices and kind of how to read the x-ray and stuff like that in a later lecture once we get through the intro stuff. But that break in the cortex. Now, there is no way I am seeing that on an x-ray, right? There's just not. It's on the posterior aspect of the sternum. This particular one, the sternum is not shifted, it's not displaced or anything. That's a minute fracture. I wouldn't see that. Now, am I ordering a CT just to find this? Probably not, because I'm not gonna do anything for this. It's only fractured on one side of the sternum. There's no displacement. There's really nothing major to kind of go with. So I'm not gonna look at CT just to try to evaluate for that. The odds are they're evaluating for something else, and this was an incidental finding, right? Maybe the patient had been having weeks and weeks of chest pain, and they couldn't figure out what's going on, so they go and get the CT with contrast, and then they see that fracture in the sternum, like, oh, maybe this is the causing your pain, since maybe it's like right here and that's what's going on. This here is not a fracture, nor, right? That is gonna be from the sternal body to the manubrium, that's gonna be that joint space there. So that's where the anatomy comes into play, like is that a fracture or is that a joint space? No, that should be a joint space. We just talked about that overlapping 2D images assembled by a computer, okay? So, CT, right? It expands that grayscale compared to X-ray. You saw kind of what the densities look like on the X-ray, and how you were like, hey, here's that soft tissue, that subcutaneous tissue, here's that muscle, here's the bone, I can make it all out. It's varying levels of gray, right? So I can kind of tell, but as we talked about, if it's a fluffy patient, it's gonna be a lot harder to tell, right? But when I go back into here, I'm gonna go back to this one, right? You can really make the difference in each of the different little organs. The heart, the aorta, right? Muscle, subcutaneous tissue. On a CT, a lot clearer than an X-ray because it has an expanded palette of gray colors that it can use because of the detail of the machine and the number of images that it gets, okay? Fast imaging, great for trauma. Like I said, the majority of these things can be done in less than a minute. It's great for trauma in a certain situation, and that is your patient is stable, right? If your patient is unstable, and we'll talk about later what to do for those unstable patients, do not send them to CT. Most ERs don't have a CT scanner in the ER, and they have to go to the diagnostic imaging or the radiology department. Patients die in CT. I'm not saying that to be dramatic. If you send an unstable patient to CT from the ER for wherever you're working, get ready because in about 5 to 10 minutes, you're gonna hear code blue, CT's radiology, code blue. Just something about it. Patients code in CT. Do not send them if they're unstable. I think I dealt with multiple codes when I was a CT tech because they're like, we just need it. Okay. When you're the tech, you don't know if they're stable or unstable, you just say bring the patient down. And they show up, they got 17 monitors and like 2 nurses and a tech, and you're like, all right, we gotta get it done. And they would code. So we'll talk about what to do with those patients, but that's an important part of the trauma of, are they stable or are they not stable? All right. Is that cheering? Somebody else got promoted. All right. It is technically considered cross-sectional imaging, right? Because it's coming from different areas and it does the cross-sectional and then it gives you that 3D picture. Newer modalities that are coming out are starting to do more 3D reconstruction like that knee I showed you, but more importantly, they're doing it in this aspect, right? Colonoscopies. They can now do virtual 3D, like virtual colonoscopies via CT and 3D imaging by just taking the scanner and kind of pinpointing the area they want to look at. That's what these little crosshairs are. They're pinpointing the area they want to look at, and the machine can recalculate and give you like this virtual kind of inside of the colon area. It's not as good as a colonoscopy, but sometimes it's at least something, depending on kind of what's going on. And then this is one of the areas where the 3D remodeling is really nice, pelvic fractures. So we got pelvic fracture here, and then here in the pubic symphysis, that's separated. Pelvic fracture here, and then here in the pubic symphysis. With pelvic fractures, there can be a lot of fractures going on in the pelvis that even with a CT might not necessarily stand out until they make this 3D reconstruction. They go, oh, it's not supposed to bend that way. Okay, let's figure out what's going on here. There's probably another one here in this SI joint over here maybe. I would want to draw my attention to it. Some sacral fractures. So there's quite a bit going on in this pelvis. So this patient has a unstable pelvis. They wanted to make sure, again, before they go in and probably surgically fix this back, want to hit all the areas before they go in and do it. So we're starting to get more modalities and that kind of stuff. Now, how do we talk about things, right? When we're speaking to people about our CT scanners, when we're looking at it, and we're talking about our other colleagues, radiology, that kind of thing, how do we talk about it? These planes are important. You have to understand what you're looking at and why you're looking at it, okay? So, axial or transverse. Axial is the term that we use in medicine for CT scanners or MRIs, okay? These same planes are gonna be for the MRIs, but axial is the term we use. You may have learned it in A&P as transverse, right? But we use axial. So, technically, they're interchangeable. And nobody's gonna, hit you over the head with a frying pan if you say transverse instead of axial. Just know that axial is the term we normally use. And that's cutting from head to toe in slices. Just like this, all the way down. Those are your axial planes, okay? That's how the CT scanner in the middle here and the MRI scanner, that's how they get the images. One scan, axial all the way down. Then, on the back end, after the patient leaves the room and is headed back to the ER or headed back to wherever they go, the radiology department will tell the computer, hey, thanks for that scan. I now want you to give me coronals and sagittals as well. So this is post-processing. They don't get scanned 3 times to get these 3 different sets of images. They get scanned once to get the axial. It's a lot of radiation, so we just do them once. And the computer goes through and then slices coronals and sagittals. So sagittals are from left to right or right to left, okay? And then coronal is front to back. If you have a hard time remembering which is which, think of your sutures in your skull. The coronal suture comes across this way because I'm making slices in that direction from front to back. The sagittal suture goes down this way because I'm making slices from left to right. The sutures line up with what we call these planes. Now, this goes with X-ray too. We haven't really talked about it yet. But, so for CT, the patient lies on their back, head at the top of the bed, feet at the bottom most of the time. Patient positioning depends on the patient. But the biggest thing is when you're looking at this, the feet are coming onto the screen towards you and the head is going into the screen, okay? So the easiest way, that can be confusing. Feet, where are they at? Which way am I looking? What's going on? That can be very confusing. What I will tell you is on CT and X-ray, I'm gonna look at it like you guys are. I put my hands up, and it's the opposite. My right is their left, my left is their right. Why is that? Because I'm looking at the patient. It is set up as if the patient is looking at me and I'm looking at the patient, because that's how we do care, right? So that is how the image is gonna present in that way. So always think about it, even from an x-ray standpoint, like if you have a chest x-ray, it's as if the patient's standing in front of you, and it's the opposite. Your left is their right, your right is their left. Okay, instead of trying to feet and head and I don't know, and then just, if you do it that way, you'll never be wrong. Question I always get every semester is, well, what happens if they send it to me and it's not flipped that way, or it's not the way it's supposed to be? That's not on you, right? That's part of the protocol for radiology techs in the department to flip it the way it's supposed to be flipped before they send it over. They might shoot it in some weird angle or do something funky to get the pictures they need, but then they're supposed to flip it the way it's supposed to before it even gets to you or the radiologist. So you can safely go with that assumption that it's supposed to be that way, right? So when I have a CT scan, reason I'm good at that is without a right or left marker, which I labeled this here, you should be able to tell me which kidney that is just by looking at this slice. Right? Right kidney because on the left side. On top of that, look, the liver and the gallbladder is over here. Right? So you should be able to look at this and know which kidney is which, know whether or not this is liver or spleen, depending on the side of the body that it is. Same concept when we look at a chest x-ray. If I haven't labeled it right or left, you should be able to tell me which shoulder is right and which shoulder is left, even without a marker on it, because your right is their left, your left is their right. That doesn't work, like we talked about, if I have one wrist, or one hand, or one forearm, or one elbow, because I don't have anything else in the torso area on the imaging, or the abdomen, or the chest, or whatever you want to call it, area on the imaging, to help me understand this whole right-left thing if I just have a singular bone, or a singular knee, or something along those lines. Right? Because I have nowhere to orient myself. But if I have the whole body, that's how that works. Questions on that? Does that make sense? Okay. Hey, look, it's this thing again. Right fluid above soft tissue. Okay. All right. So this is more showing you the difference between the same chart we looked at for x-rays of the varying gray scales and colors, and now with the Hounsfield units, that more detailed stuff. 3000 is metal, that's the white. Negative 1000 is air, that's the black. Why is it not 3000, negative 3000? I don't know, Hounsfield created it, right? But if you look, bone on CT is 1000. Look at soft tissue, so fluid is water, and soft tissue is like 40 to 80. So now you kind of see here why I say on x-ray, fluid and soft tissue are pretty much the same. They're so close, they're barely separated by the CT scanner, which can give me even more detail into the densities. So this is where you can, when we talk about that cyst, throw that little thing on there and you're like, oh, it's right around 0. That's water, that's fluid, that's a cyst. Or, yeah, it's like 80 to 100. That's soft tissue, that's probably a mass, right? That'll be helpful in clinic. Fat, negative 50 to negative 100. Lungs, negative 4 to negative 600. Why? Because there is still tissue there, but there's still a lot of air there. If I were to take all the air out of the lungs, right? All of it, like post-mortem patient, and do a CT scan, that lung Hounsfield is going to be more towards the 0, because it's going to be like more in that direction, because it's going to be more dense because there's no air in the body whatsoever, right? But for us, and most of the patients you'll be doing, hopefully all of them, they won't be post-mortem. It's a bad day. And your lungs will be between negative 4 and negative 600. You do not need to memorize the Hounsfield units, okay? I am not going to be like, what are the Hounsfield units? What's soft tissue on a CT scan? This is more to help you understand the concept of what you're looking at, the densities, and this in particular will be beneficial for you in phase 2, right? You'll look really smart if you're in the ER and you're trying to evaluate something and you're like, oh, I remember that thing, hey, let me pull this up real quick, and you pull it up, and then you use that as part of your, hey sir, I just got a CT scan back, there was this mass in the liver, but I went ahead through the hospital, you just looked at it, it looks like it's a cyst because it's, around 0 or whatever, and you just like earned bonus points for knowing what the heck you were doing without having to be taught that. If you can have this kind of at the ready and go. There are some slides in this course that I present to you, especially when we get to some of the disease processes, that, and I will tell you which ones those are, right? And I'm like, hey, I'm not testing you on this, but this is beneficial for you in clinic. So set it aside, you can use it in phase 2 to help you out. All right. All 3 of these were done by one scan. It's another thing a CT scanner can do. It has different algorithms. So you do one scan, and depending on what you're looking for, you can change the way it looks. It's kind of like when you're driving at night, and you got those dang brights behind you, right in your rearview mirror, and you kind of flip that switch, and it dims them a little bit, right? Same concept here. That's what this does. There's different windows. So alpha is called a lung window. Look at what it did to all the soft tissue in the bones. It whited it out, right? That's not very detailed. I can't really see it that well. But boy, does that lung tissue in the, bless you, and the vasculature in the lungs really pop out. I can really see that tissue and all of the vessels in the vasculature. So that's really good for looking at lung concerns, lung tissue concerns. Bravo is my soft tissue window. So now look at my lungs. They're all black. I can't really see that lung tissue because I don't care about it. I want to see the soft tissue. The heart really jumps out. This is with contrast, but I can see all the chambers of the heart and the ascending aorta and the descending aorta. Ascending aorta, descending aorta. We'll talk about some of the heart stuff in the second block. I can really make out my musculature really well, combined with my subcutaneous tissue, right? All of that is kind of sitting in there. So that's my soft tissue window, so I can do that. Charlie is what's called a bone window, right? Look at how much more detailed this scapula and this rib is compared to the other 2 pictures. Now I can really make out that cortex. I can make out that medullary or cancellous bone area, depending on what area of the body we're talking about. And it allows me to really see, look at the vertebrae, right? How well I can see the vertebrae compared to the other 2 pictures. So bone, lung, and soft tissue are the main ones you're going to use. And the nice part about it, again, you don't have to rescan the patient. This is something you'll do. You'll have it on your screen. You're like, I want to look at that a little better. You'll just hit a button or click a thing on a toggle on the thing, and it'll change it to these kinds of images. So you can see how beneficial CT really is. Okay, bad joke. Kind of bring up the monotony of the slides. And that's true though. It is a lot of gray area because you're interpreting things. You're going to interpret these images as adjunct, right? Very rarely are you ever going to make a diagnosis based off of imaging alone. It's a gray area. I think this is what's going on. This is what the patient told me. This was my physical exam findings. This is what I'm diagnosing. The reason I have this in there is because what do you think radiologists don't do? They don't diagnose, right? Because they never saw the patient. Radiology is a field of people who got into medicine and realized they hate people. They hate people. And so they still want to help, but they don't like dealing with people. And so outside of certain interventional radiology studies, they don't. And they just sit in a dark room and stare at a screen like you guys are right now. They just look at hundreds of these things all day long, every day. In civilian world, they get paid like per study, so they have no problem doing as many as they want. But there are, in civilian sector too, PAs that do radiology. So that is something for my guard reserve that you could potentially do if you really want to. Don't use this course to determine whether or not you want to do that. Wait till you get out to phase 2, get some practice doing it with the actual radiology department and see if you like it or not. But my favorite 3 words at the end of almost every radiology report that you are going to have, and you're going to hear this a couple of times throughout this program, is you're going to get the image and you're going to say, hey, patient has this, that, whatever's going on. Radiologist is going to look at it. They're going to tell you what they think they see, and then they're going to end with, please correlate clinically. That is their big middle finger to you to go, you figure out what to do next. Because I didn't see the patient, right? The radiologist didn't see it. So they're like, yeah, we think this is what's going on, but please correlate clinically. Which then it falls back on you to use your patient history, your physical exam, what's going on in the patient, and the radiologist reading information to figure out, is that something we're actually concerned about, or is it not? Or does that help my diagnosis or not? So that's why I say it actually is a lot of gray area, because it's ambiguity, and you gotta kind of make that call. All right. So again, just more CTs of kind of showing you the detail of a fracture. Okay, so here's the fracture. But now look when I do a CT, look at how much more detail I get on that fracture. Very, very beneficial if it's something that we think is going to require surgery. Same thing here. X-ray shows me he's got a nail in his skull. I don't know where. I don't know what direction. I don't know how bad the damage is. So we're going to get a CT. What do we think this black is here by the nail head? Air, right? Cavitation, a couple of different things. So I like your thought process. This is one of those now. What it is it's called artifact. Because the CT has so much radiation and it's super sensitive, some metal will create this artifact, this reflection, right? The sensor couldn't get any information off of this because the radiation kind of reflected around and it skewed some of the results. How do I know that? Look how bright white my nail is, right? And you can see kind of like these little starring effects kind of coming off of it. So that's just some artifact because that must have been a really dense nail and the CT caused that. Could there be air because it came through the head a little bit? Maybe, but not necessarily that much. And this is more just artifact because you can see how there's a thin black line around the whole thing. That's because of it's not getting any data from that because the metal is just reflecting off all that radiation. Same thing on my slice right here, that's what this is. So sometimes CT can hinder, but you still gotta get it done to get the detail you need. Same thing's happening here, right? Bilateral total hip replacements, those things are dense. For those that don't know, those are dense, especially when they're the older ones that are like, now they're starting to come out with like these like plasticky, plexiglass type, replacements. But back when they were pure on metal, that's not air all in there, that's just artifact from those devices. What type of slice is Bravo? Axial. What about Charlie? Coronal. Good. And then this one here? Also coronal. Good. Good. Okay. So one of the benefits for CT, right? Cross-sectional imaging gets us a lot of detail with that expanded grayscale. We can really make out those different tissue densities, gives us a lot of information. We can manipulate the data. We can do the 3D recon, or we can do those coronal and sagittal slices afterwards to give us even more information, to be able to pinpoint stuff. It's widely available. Nowadays, even most of your deployed settings are probably gonna have at least a 16 slice CT scanner, right? So a lot of times you have them even there. We'll talk about one thing in block 2 where you would only use it if you didn't have one, because if you only have one CT scanner in a deployed setting, what do you do if it goes down? Figure something else out, right? And that can happen, right? So if anybody's been deployed, right, how many times has every piece of equipment you deployed with worked 100% of the time of your deployment? None on mine. So if some of you are saying, oh yeah, it happened, then congratulations, you got lucky. Cons, ionizing radiation, just like X-ray. Cons, it's a stationary system, right? So unlike the X-ray, I can't bring this to patients. I don't have a way to do this bedside. They've got to go to the CT scanner. Yes, they are starting to come out with some portable CT scanners now. A, they're super expensive. B, they're not really as good as the main ones. And C, the government's not going to pay for them because we have ones that we can use. So that's coming out there. For some of you who go to the civilian sector, you might see those if you're working at a place that just has bottomless buckets of money like Johns Hopkins or whatever other hospitals that are out there that have that. I'll do all the research, but for the most part, they're stationary systems. Uses, abdominal or chest pathology. We'll talk about pulmonary embolism later. Coronary angiography, so that's basically the vessels of the heart, looking at the arteries that are going around the heart. Trauma, if stable, if the patient's stable. On the test question, how can we tell if a patient's stable or not? Vital signs, or if I say they're stable or unstable. Words matter, yeah.
Would like a stroke be an exception,
Exception to what?
like stability and getting a CT?
So again, it depends on vital signs. Are they stable or not? If they're unstable, right, because vitals, so you can have a patient that's unconscious or sedated and still be stable, right? Stable is determined by vital signs, not necessarily patient presentation in that aspect. I don't know if that makes sense. Because I'm trying to figure out what you're asking as far as, exception to what policy, I guess I should ask.
Well, like you're just saying if they're stable or unstable, what if they're having a stroke and you have that window where you wanna get them scanned quickly?
So strokes, you'll learn more about neuro. Getting an acute CT in a stroke, probably not really gonna benefit you very much. In the aspect of where a lot of strokes need MRIs in order to find the strokes, and we'll talk about MRIs a little bit later, a little bit here in this lecture. But my question is, if you know they're having a stroke, then does your CT scan give you any additional information needed to treat that patient? How? You'll learn more when you get into neurology. I'm trying to stay out of their toes and trying not to muddy the waters a little bit. Whether they're having a stroke or not, if they're unstable, regardless, do not send them to CT. Just leave it at stable versus unstable as far as whether or not you should get a CT or not, right? What you will learn is most acute strokes don't show up on CT, even if there is a small bleed. Right, that's kind of what the gist I'm getting at on that one, right? And if it's a massive stroke, then they're gonna be unstable because they're bleeding out of their brain, and that's gonna be a concern as well. So just use it with the vitals of the stable versus unstable for right now. Neurology will get into some more nuances and details of appropriate imaging for strokes, because it gets a little bit more muddy, a little bit trickier, depending on the time frame, what modality do you use, that kind of thing, because MRI is the best for that. But there's no such thing as an emergent MRI, and we'll talk about why in a little bit. Fractures at any joint. So if you notice a lot of those CTs we were doing, they were intra-articular fractures. Most any joint fracture requires a surgery, so that's why those are gonna get a CT, so the ortho folks know exactly what to do, all right? And then, like I said, don't know the truth. This is for you guys, I'm not gonna belabor it. Know which way axial cuts run, sagittal and coronal, okay? Here's a caveat with this. Every study for a CT, the patient is lying down. There are no standing CTs, there are no standing CT scanners, the patient is lying down. So that's nice, because I don't need the patient to be able to stand up to be able to do the imaging, so that gives me a more of a range. But it does mean I gotta transfer the patient from the bed to the CT scanner and that kind of thing, which is another reason we stay away from those unstable patients, because transferring them sometimes is all it takes for them to completely code and kind of tank. We use contrast agents for CT. Remember the contrast slide, here it is again, right? Depending on the area of the body we're doing it, that's the contrast we're going to use. Okay. A little more detail, okay, on when we do CT with contrast versus CT without contrast. Now, there's IV and oral contrast, right? And so if you just remember IV for vasculature, organs, bowel mucosa, oral for anything that's GI tract, you got that situated. Those are both considered CTs with contrast. It's just one is oral and one is IV, which means one is iodine-based and one is barium-based, okay? CT without contrast, head trauma and kidney stone studies. That's about it. We will talk about both of those when we get to those actual areas of why they're without contrast. Okay? Sometimes they'll do studies with and without. You don't need to worry about that yet for this course of what's a with and without. But a generality would be if you're like trying to look at the pancreas specifically, the liver specifically, it's nice to have one without and then nice to have one with. So that way you can compare the two side by side and go, what did it look like by itself? Sometimes we see a mass, we don't know what it is. And then with the contrast, does it light up like a Christmas tree? And does that tell me information? You'll learn more about that in GI. And every once in a while, if you ever hear triple contrast, feel for that patient. Because they're getting IV contrast, they're drinking contrast, and they're getting contrast in the other end as well. Doesn't happen very often. Doesn't happen very often at the same time anymore, but if you ever hear triple contrast in a report or in a study, I want you to know what that is. But biggest thing here, know your tube for without contrast, oral versus IV, what does it highlight, what does it do, so that way you kind of have an idea what you want to order and what type of contrast based off of what the situation is. Okay. So the CT with contrast, right? Angiogram with contrast, either way, we're looking at vessels. So what you're looking at here, ascending aorta, descending aorta, pulmonary artery. Ascending aorta, descending aorta, pulmonary artery. So what does that mean? When I give the contrast, or when they give the contrast via IV, it flows through our vascular system, right? So our vascular system is vast, has lots of vessels, and it's only gonna flow through once, and then it's gonna get filtered out by the kidneys. Which means, depending on what you're looking for, this is all about timing. So what'll happen is you have to be very clear when you're telling them what you're looking for. Are you looking for a PE and you want them to time it on the pulmonary artery? Then they're gonna scan it at a certain time. We know medically how much time it takes to get to certain organs. When I say we, I mean like medicine in general. And the radiology folks have that information, it's how they build their protocols. So the time is gonna be different if you wanna look at the liver versus you wanna primarily look at the spleen or the pancreas or something like that. So it's important for you to be clear on what organ or what thing you're concerned about. If it's generalized abdomen, great, it's generalized abdomen, they're just gonna generalize it in that area. But sometimes you might be like, I need to look at the liver, or I need to look at the pulmonary artery. And so you tell them that, so that way they can time it to get that contrast in that organ or in those vessels, okay? The angiogram being the specific type of CT, that's more, the CTPA, it's a different name for it, it tells them exactly how clear it is, we'll cover that more later on, of the PE and kind of what it looks like and how to interpret it. I'm not testing you on this is one of those slides that I want you to save for your clinic. Because when you're deciding, do I order IV contrast or non-contrast, depending what I'm looking for, green is go ahead and do it. Red is it's not gonna benefit you in any way really, it's very minimal benefit. And the white is kind of like, yeah, right, you could technically do IV for some of this other stuff, but you don't have to. And again, this will help you when you're seeing those patients and you're going back to give a report to your preceptor. Be like, hey, this is what I wanna do and this is why I wanna do it. So that way you know whether to use IV contrast or non-contrast CTs. Air on CT, black, metal, white, bone, very light gray, and gray to dark gray. Same thing as X-ray, right? As far as what color, that kind of thing is just more detail, more radiation. You can get contrast to help find things out better. And we have those different kind of slices, the coronal, the sagittal, the axial, that kind of thing. Questions on CT? Okay. Mammo's gonna be short. We're just gonna talk about a couple of things on the mammo. You're there. 1 in 8 women will develop mammo or will develop breast cancer in their lifetime. 1 in 8 women. Doesn't mean they're dying from breast cancer, it means they'll develop it. Nowadays, since we started mammo screening, we dropped 40% in deaths from breast cancer just between 1989 and 2017, since we developed our screening protocols. You're gonna have a lot of women who don't wanna get this done. All you can do is highly encourage them. I would even go as far as highly encourage them and put the order in for them. If they don't use it, they don't use it. But in some places, putting the order in for them causes the radiology department to call them and go, hey, we got an order for your mammo, can we schedule that? And sometimes that phone call when they're on the phone with somebody is what gets them to schedule it, right? If they don't do it, they don't do it, you've done your part, right? That's key. So we're gonna cover mammo just a little bit here. Began in 1913 with just studying excised breast tissue. We weren't even using it on patients yet, okay? They started in the late 40s to early 1970, kind of putting together that excised breast tissue imaging and clinical correlation going, is this actually a tool that we can use to find breast cancer early? They determined yes it was by the end of 1970, and they started screening mammography, okay? Here's what the machine looks like. This is the console that the tech stands at. This is the patient. This moves up and down, so the nice part about it is if you have a patient in a wheelchair, they can still get their mammo done, they just bring it down, if they can't stand up, that's okay. And the machine kind of rotates and moves at the angle it needs to. You'll see what that is. This is the meat and potatoes of mammo, okay? If the patient is asymptomatic and you're just doing their screening because they're 40 plus and they need their annual screening, now, there's multiple guidelines out there. There's the USPSTF, there's the American Cancer Association, there's different guidelines. We, for this class, are going off of what's in the slides, because some say 40 every year, some say every other year. I think some still say 45, right? This is what we're going off of, this is what you'll be tested on. Because I think the USPSTF ones, which is what the military uses, is still annual at 40. So, asymptomatic patient, annual mammogram, beginning at age 40, okay? Diagnostic, 2 different studies. Screening is I'm just looking to make sure there's nothing there, you have no issues. Diagnostic is I'm concerned there's issues there, so we're gonna try to get something with a little bit more detail to figure that out. That is patient with breast symptoms, so pain, a mass, discomfort, drainage, whatever, something, discharge from the nipple, or those who had abnormalities on their screening. Got a screening mammo, it wasn't clean. Not sure what it is yet, so we're gonna go back and get a diagnostic. However, there's a caveat. What's their age for the diagnostic? If they are 30 or older, you get the routine diagnostic mammo. If they have breast symptoms and they're 30 or older, we jump to the mammo. If they are under 30 and they have breast symptoms, we do an ultrasound first. This is our first variance, and when it comes to radiation versus no radiation, can anyone guess why we're gonna do an ultrasound first? They're young, right? They're young. There's 2 reasons. One, we don't want to give them a bunch of radiation if we don't have to at a young stage, especially in an area of breast tissue, which can be sensitive to radiation. It's a low amount of radiation, but still no radiation is safe, right? All that comes with the risk. And 2, a lot of your younger women are gonna have more dense breasts because they haven't gotten older yet, the tissue hasn't atrophied yet. A lot of them are gonna be thinner, so the breasts are gonna be more dense. And so sometimes mammo can be hard to evaluate and see, and an ultrasound can get us those answers better. So under 30, with breast symptoms, ultrasound, yes.
Would family history change these parameters?
It does not change those parameters at all. Yeah, good question. Family history does not change the parameters. Family history, which you will learn in women's health senior semester, does change the when do I start my screening, okay? But it does not change the parameters of if a patient comes in with breast symptoms, do I order an ultrasound or do I order a mammo? That's gonna be based off of age, okay? And I got it even down here at the bottom. Ultrasound is your initial study in average risk symptomatic patients under 30. You'll get more into the risk factors in women's health. Okay, but for this course, it's all based off of age. And on that note, take a 10-minute break, come back at the top of the hour. Nope. Well, top to bottom. So they run from top to bottom. Now here's score from scale. And they look at slices go from top to bottom. I'm slicing it this way, right? This way, when your image is really good. So think both of them. Yeah, think both of them, right? How you're looking at it, like a loaf of bread. And so it's not like which way that's cut where, I guess I could show you more, you know, actually kind of ask me that, so, try to figure out how, which way are you gonna do it?
Yeah.
If I give you an image,
Yeah, I know it's top to bottom.
perfect. Well, because the thing is, it's making the cuts, and then you have these slices, so maybe I can change out the slices. Instead of cuts. Okay, but yeah, top to bottom. We'll get there. They still get manuals. They still get manuals.
They do?
Yeah, okay, absolutely, but we'll kind of talk about the one case when you order something else with precedent. So, yeah.
That's my
Guess what? So what the ultrasound is, those patients that don't but the ones that have abnormalities, because it needs to be a definition and more valid study, we're then gonna get an ammo for the abnormal ultrasound. So the ultrasound is just designed to save radiation from those that don't have any abnormalities, and then you
If we're trying to save, if someone's not on the system, they are moving, would be that
not really sure, I can get where you're going with that. There's also a factor to where the only patient great, I'm gonna make sure I hit that area, all the surrounding fibers over here on the left side, because I'm trying to get that area that you're having symptoms in the area, right? If I do a screening, use your dependent, right? So what happens if that's a certain area, now we have to evaluate that, it'll move it all, it's intentional, so it's actually better in that aspect as well.
Yeah, it is team. For like your team will here, but the numbers, but it's just one. I'm sure it would be cool if they had like a doc. It's like all the guys like so you just like what things like
Doesn't matter. Flip it to where your left is their right, your right is their left.
Knowing that I ordered the CNRGP, can I look at something else? Or do I just need to know what it is?
We need to know what you ordered, we'll talk to you. Very sometimes we order an AP chest X-ray, and I'll be honest with you, if you want an AP chest X-ray, you're gonna have to order it. Because the standard is that is the gold standard, that's all the protocol. The only time they do an AP, we'll talk about it in one two, is from the patient that they can't get on the standard. So trauma, patient, ICU, you know, that kind of stuff, go through it because they have no patients. And you don't know that because you're wondering. Because you have to tell the regardless of how you do it, the appointments are there. Your left is their right every single time. Every single time. That's why you're not there yet. I haven't given you specific disorders yet, and specific names of fractures for you to look up.
Identifiable, we know that it's an issue. Do they look at the issue like that distribution?
They do. They look at what you would write in the order. This is part of our at the end of this block. It's like how would you write what information am I giving the radiologist? Correct. And so like sometimes you gotta yeah, you're right. And that's why I say like it's adjunct, right? You're never gonna die with a doctor. Now, there are times when I might run a test and have a patient be like, what's going on? Like, what's my patient information, right? Well, you actually have more information from the exam because I'm only giving you 5 options. I haven't given you the world of options, right? And that's why I say, I'll read the question and answers first, so you know what I'm asking you to look for. So when you get to the image, you can go, okay, these are the 5 things I need to assign you to. All right, let's look for each of those and see which one is that. Right? And I'm giving you information about it can only be one of these 5 things. Functions. There will be. It's going to be really specifics. What are you looking for? So when we get to it, psoriatic arthritis, right? Jones fracture, green stick fracture, Salter Harris, putting those in there so you're like, I now know I'm looking for this type of abnormality. Give me just pictures of that. It will help you kind of figure that out. Yeah. No, no. Okay.
Oh, I don't think so.
All right, let's take our seats, let me start again. So I had some good questions on the break. All right. Biggest one was, if ultrasound is not radiation, then why don't we just use it for screening, right? Really good question. The reason is, we use the ultrasound in the symptomatic patients because we want to try to avoid the radiation. And the nice part about symptomatic patients versus asymptomatic patients is, what can they tell us? Where it hurts, where it's at, right? So ultrasound, as they'll learn in our little bit later in our next lecture, is user dependent, very user dependent, right? So if you were to do an ultrasound and like someone's like, hey, it hurts here, they can get the ultrasound here and look around and look and find anything. It's more used as a rule out, like, hey, we didn't find anything, so that's good news. It's something structurally causing your pain. It could be X, Y, and Z. Now I can save you from the radiation. But if we see an abnormality on the ultrasound, guess what that patient's going to get? A mammo, to further clarify it. Because the other thing is a concern is if they're asymptomatic and I'm doing an ultrasound on the breast, there are chances that I might miss some of the breast tissue on the images that are taken, which means now I didn't fully evaluate the breast for breast cancer, whereas the mammo gets all of the breast tissue. And so that's why 40+ we do the mammogram instead of the ultrasound, and we really focus the ultrasound on symptomatic patients, okay? Because there's really no reason to evaluate the breast in asymptomatic patients until you get to 40, and then review the entire breast. Here's what the mammos look like, okay? So, this is the breast tissue. I don't need you to interpret mammograms, okay? The only thing I'll need you to do from interpreting mammograms on an actual image would be if I give you an image with a mass on it and an arrow pointing to a mass, very few pictures do I give arrows pointing to the abnormality, because I'm telling you I don't need you to interpret mammograms, right? If I give you a mammogram photo, I will have an arrow pointing to something, asking you to basically tell me what type of mass is this, right? And we'll look at those descriptors here in a little bit. But this is what they look like. When they get both of them done, they will put them, the pictures side by side for the radiologist, so they can do this nice side by side comparison when reading the mammograms, okay? Here's how the images are produced. Okay? Craniocaudal view means, so it's the right breast, RCC, right craniocaudal. Which way is it going? From the cranium area down caudal. Right medial lateral oblique. Radiation is coming from medial, going to lateral, and it's at an oblique angle. That's what an RMLO means. Alright, what's going to happen is you're going to get a report, you're going to order a mammo. The mammo views that they do maybe weren't conclusive, so the radiologist is going to come back and go, hey, need additional imaging, please order specifically RMLO. Or please order ultrasound, or please order MRI, and then you have to go in and you have to order it because they can't order it because all the reports come back to the provider who orders it, right? And they're not the PCM. So that report comes back to your desk, you have to order the new images, call the patient, tell them to go back. Fun times. But here's kind of what it looks like. They're uncomfortable, which is why most patients don't want to get them, right? And then the answer will be, hey, well, I don't have breast cancer in my family, so why do I really need this? Well, because somebody in every family was the first one to have breast cancer, right? Somebody had to be patient zero in that family tree to get breast cancer. What if it's you? Let's make sure it's not. Same answer. But speaking off the cuff with you guys, it's not how you should talk to the patient. Okay, so fat appears gray, right? But signs of breast cancer or abnormalities are whiter and more bright, okay? The short red arrow is that cancerous lesion. So I would point to this and say, how would you describe that lesion? We'll talk about how to describe it here in a little bit. What we got up here is a reactive lymph node from that breast cancer. That lymph node is angry, it's more well circumscribed, right? It's just reactive. And those are the kind of the terms we're gonna use here in just a second. You don't need to memorize this. This is just showing you the differences in categories of the breast density. This extremely dense one, a lot of the younger female breasts will look like this, especially in their 20s, which is why, I mean, how hard is it to pick out a mass on that thing? Kind of difficult, right? And most people won't need to get it done, which is why we go, one of the reasons we go ultrasound. Save the radiation and save the fact of something like this. But you don't need to memorize these, but these will be beneficial for you when you get your reports back, because they're gonna say BI-RADS 1, BI-RADS 2, that kind of thing, give you the categories. Dense breasts sometimes are going to need to do different type of imaging, right? Like a breast MRI. This is an FYI slide, pay attention to the upper right-hand corner. Don't study this, don't memorize this. But there's also a digital breast tomosynthesis, to where it basically is taking it, and it's kind of like a CT scanner, but it's not a CT, it's a special modality that they can do to really try to take those dense breasts and slice it up into a bunch of different ones to give the radiologist a better point of view. So it's another option that's out there. Why is cancer difficult to distinguish in dense breast tissue? We just covered it, it's very white, bright, it looks the same. Here we go. This is the slide you want to focus on. Normal mammogram, but I got arrows by the abnormalities, right? So if I give you a breast thing, I'm going to give you the arrow, and I need you to tell me, is it well defined? Can I draw a nice little circle around it? Can I look at it and go, looks like somebody took a coin and stuck it on the breast tissue before I did the mammogram? That's a well-defined lesion, likely benign. Maybe a reactive lymph node, maybe a cyst, don't know right now, but likely benign. However, spiculated is what we have in the cancer area here. Take a look at it. It's more bright white than the surrounding tissue compared to my normal, but I don't have clearly defined edges, right? It kind of comes out here, 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 kind of comes out here, here, and here, right? So it's got a centralized dense lesion, but then it has like these lines kind of radiating from it, and there's no clear starter end to it. That's a spiculated lesion. That's a concern for cancer. So that's the extent of reading these things that I need you to know about. The rest of it is going to be, when do I order it? What type of study do I order based off of the patient presentation, so we order the right thing for the patient, okay? Because mammos are so sensitive when it comes to making sure we get the right read. It's one of the few things that I will look at you and say, as a family practice PA, every time I read a mammogram report from the radiologist, I don't even look at the images for those. I just take the report at its finality, you know? Yeah.
What about breast augmentation? Is it gonna show up super white or?
Yeah, it will not. The implant will, right? We had that question on the break too. You still get mammograms, but it will separate. So some of them, it depends on the type of mammogram it is, but they have special settings that they can do to make sure it doesn't affect the image.
Does it hide the cancer easier?
It does not. It does not, because of the settings that they can't order. So that's why it's important to do patient history, because you have to order, when you put in the mammogram, there's a special like implant mammogram order. So that way they know what settings to do with the machine. If they were to do regular mammogram settings, then it may not be a good picture and it may hide some stuff, but they have special settings that they can do to still do the mammogram. Helpful if you know, or if the patient knows, if it's a pre-pectoral or post-pectoral or subpectoral implant, because that will be extra information that will help them out. And we'll take a look at actually some pictures of that and kind of what that looks like in that aspect. And so you'll see that here in a second. So what kind of things when you're talking about stuff, right? Spiculated versus cystic. So that well-defined border will say cystic, spiculated cancerous. Is it mobile or fixed, right? That's you doing your physical exam, right? Was it a mobile lesion or was it fixed, like I couldn't move it? And then was it fluctuant, rubbery, firm? What did the lesion feel like? So when is this beneficial? This is beneficial when you're ordering the study. Symptomatic patient, you do your breast exam, and you're like, oh, I have this mobile, firm mass at the 3 o'clock position. Again, giving that info to the radiologist so they know an area to make sure they focus on and take a look at. Or if it's an under 30 patient, telling that ultrasound tech where the area of concern is, so they make sure to get that area when they're doing their scan, right? Yes,
These don't have like a general area where they're usually in, they can be anywhere
it can
within
be
that tissue.
anywhere in the breast tissue, including up in the axilla and the tail of the breast, where a lot of people often kind of forget to do their physical exam and kind of palpation, which you guys will learn in senior semester. But yeah, they can be anywhere where there's breast tissue, males or females, right? Males or females. So what are the pros and cons? So the pros and cons are almost the exact same as regular x-ray. Inexpensive, readily available, portable, quick, and ionizing radiation for the cons. What do we use it for? Screening or diagnostic breast exams. That's about it. Patient positioning, not a concerning factor, because as I told you, that thing will move to the patient, so it goes up and down, the thing can rotate whichever way it needs to be able to, if the patient's like laying on the side, they can rotate it to where it looks like an oblique, but really for the positioning, it's a normal one, and they can work that. So patient positioning, not a concern with mammo. Difference in appearance of a breast finding and a neoplastic lesion, right? So that's gonna be those well-defined borders versus the spiculated areas. Here are your breast implant memos. Still the punchline, it's okay. But you can see how with the different settings, it does not. But what it can do, it can make that breast tissue look more dense because it's being compressed. Yes, sir, sorry.
Your answer, for like the move, like describing the lesion as like the movement texture,
Yes.
for like mobile and fixed, is one lean more towards like it being cancerous or benign, or?
It depends. I've seen both, right? Your mobile ones are less likely to be cancerous because like maybe it's a lymph node and those can kind of float in with the lymph chain. Whereas your cancers a lot of times are more often than not fixed because they're in a certain area, but that's not an absolute. So yes, I'm more concerned about firm fixed masses than I am some of the other stuff, but I don't want you to put that into your head because regardless of how the mass is, regardless of how you describe it, it needs imaging to verify what the heck is going on. So I don't want you to find something that's like, well, this is probably benign, and then not get the imaging. Does that follow? Okay. Yes?
What is that line?
So this is gonna be, let me just make sure I don't have it in my notes. And, yep, I thought so. Okay, so this is gonna be the line of showing you kind of where that cutoff goes for pre-pectoral or subpectoral. And the yellow arrows are showing you where it's at after the implant. So this is the initial kind of cutoff of the pectoral muscle right here. Mammo doesn't show muscle very well, so that's why it's pointed out and showing it to you. And then if they put the implant underneath the pectoral muscle, that line shifts up to the front a little bit and the implant's below. If they put it on top of the pectoral muscle, that line shifted now to go behind the implant. So that first one in the preoperative is that end of that pectoral muscle. Now where am I putting that implant? Okay? These are silicone implants. Again, foreign bodies that probably should have been removed before the mammogram. But some can't be. Some can't be. Okay? So this is just going to show you, you still order mammos on patients with implants because it's better than nothing. And breast cancer can still present. However, if I'm concerned that a patient with implants has a leak, has an integrity issue, especially due to the silicone ones. The saline ones, yeah, it sucks, it's kind of painful, but there's no really major long-term health concerns with the saline implant. Leaking a little bit is just saline, right? The body will absorb that. Silicone is an issue. You're gonna order an MRI. You're gonna order an MRI for concern, only for concern of structural integrity for silicone breast implants. Right? The older it is, the more likely it is to rupture or leak, so now we're talking about our older patients probably who've gotten silicone implants, okay? Here's what the breast MRI looks like. I don't need you to dictate that, but it just gives you an example of the detail that it can give. So they lay down in this special little chamber and it gets all of the tissue and it'll scan through like a CT scan of a bunch of slices that you can't see here. And it's gonna be looking for any type of leakage of the implants or causing any kinds of issues. So the biggest thing is, Yep, biggest thing is implant patients still get mammograms. They still follow the screening mammogram rules, they still follow the diagnostic mammogram rules. Unless you are concerned for a rupture of a silicone breast implant or a loss of integrity, a leak, a rupture, whatever you wanna call it, that gets a breast MRI. Because if there is a concern for that, do I really wanna do a mammogram and squish the breast and the implant trying to get imaging? Nah, it's gonna make that leak worse. It's gonna push more silicone out into the breast tissue and cause more symptoms. So we do the MRI where they just lay there, the breast kind of hang down, there's no compression on the breast. It does that full evaluation to see if there's a leak in the breast implant at all. What do they do after that? Well, it just depends. They might go in and take it out. They might go in and take both out, put new ones out. That's up to the surgeon. Questions on mammo? All right, MRI. Lots of history of MRI. This is the most important. Okay. I know, bad radiology jokes. I think I did chocolate with these. Yeah, classes later today. Okay, so FYI, right, not gonna give you history, but here's a basic history, or not gonna test you on history, but again, another Nobel Prize by Bloch and Purcell because they discovered MRI. So if you want a Nobel Prize, find a new type of diagnostic imaging that we can use in medicine, and we'll give you a Nobel Prize. I think we're running out, but you never know. They started really clinically in the 70s using it for correlation for oncology, so cancer treatments and cancer patients and trying to find some stuff. And then they started to really, got another Nobel Prize for Mansfield. We had those Hounsfield units. Mansfield was like an MRI thing, same concept. Because he came up with this new special echoplanar imaging, and then this other guy, I can't say his name, came up with the different field gradients for you to use. But look at the portable compared to our standard, where we started to where we are now. Big, big difference. Here's your MRI machine. Notice it's more closed off, right? Notice it's more closed off. These are patients that if they do have an issue with claustrophobia and it's been documented, you might need to give them a little something to calm them down. Because whereas I told you a CT takes seconds, this takes 45 minutes to 2 hours, depending on the scan they're doing. This is not a quick scan. So if they have issues with claustrophobia, this is the time they may need a little additional medication. You'll hear that in pharm. But here's the kind of images it produces. Notice the difference between this and CT, right? The smoothness, the soft tissue. Notice how the bone can be two different colors. What the crud is that? Don't worry about it. We're gonna talk about T1, T2 weight and stuff. I don't need you to know that. But without the colors, just look at the detail of the soft tissue and the different areas of the body and how it looks different from CT. The best way to figure this out is when you're doing your studying, pull up that slide that has both of them, or pull up, we have plenty of slides in the slideshow of a CT of that area or an MRI of that body part and look at the difference side by side, right? Train your brain to see the difference on that. So, really good for soft tissue, like I can see my ACL here on this part here. I can see my ACL. I'm not going to require you guys to pull out an ACL. I'm not going to require you guys to pull out a labrum and be able to detail it. From the MRI standpoint, for the most part, it's going to be, do you know when to order them? And when it's appropriate to order them, which we'll talk about with those conditions. Do you know you're looking at an MRI? If I give you the picture, and what type of slice is it, axial, coronal, sagittal, can you say, yes, this is an MRI, right? And then there are a few things in the spine, which when we get there, you'll see what I'm talking about, that I would ask you to be able to pull out an abnormality, but it's something that is not minuscule, like it stands out. Once you see what you're supposed to see, you're like, oh, that's what that is. And we'll talk about that when we get there. But that's gonna be the extent of your MRI stuff, okay? YouTube video of how an MRI machine works. It's magnets, it's not radiation, lots of loud noises and banging, okay? I am not, this is in here because I had somebody, actually 2 semesters in a row, like was super, like, I need to know how this thing works. So, FYI, don't bash your brain. Biggest thing is it's protons, magnetic field, it's not radiation. It's not radiation. Okay. This is the same scan, this is that T1, T2 stuff, it just goes to show you how things can stand out differently depending on the different scanning types that they do. Alright, you don't have to memorize that, but that's why I don't want you to mirror. You notice how we haven't talked anything about what color is what on MRI, right? Because it depends on what T1 and T2 you're looking at. So, don't try to associate colors with MRI, because sometimes fluid in the ventricles is black, and sometimes it's white. Right? So I don't need you to hit your head up against the brick wall on that one. But you can see the detail of the MRI from the brain scan, and then also look at my spine here. Right? Look at how nice that spinal cord comes down behind the vertebrae. I got my CSF on both sides, whether it's white CSF or black CSF, it doesn't matter. The point is I can make out that spinal cord, I can make out the CSF, I can make out all the intervertebral disc spaces on this MRI. That soft tissue stuff just kind of pops, and it's there. On the CT, I'm not making all that stuff out. Okay? And we'll look at some spine CTs, and you'll see how you can't see the spinal cord. You know where it's supposed to be, but you can't separate it from the CSF and the spinal cord. The soft tissue and fluid look the same. Just more pictures of the different brain imagings. Kind of, again, to compare what a brain CT looks like compared to different types of MRI. Quality difference out there. Smooth brainy versus smooth. More T1, T2 stuff. Okay, so let's show you what I see here. Again, not gonna make you read it, but I wanna help you understand. So, knee, patella, so I'll just draw it up here for you guys, it's working now. So I got my patella here, I got my femur here, I got my tibia here. Everybody see that? Okay, so, what I have here is my ACL. See how it connects the tibia up to the femur. That's where it's supposed to be. This is the start of the PCL. Can't see it go all the way up yet because I need more slices, right? If I were to scroll through it, I would be able to see that. So now that we know that this is the ACL, this nice little connection, now I come over here, I got my patella, I got my femur, I got my tibia. Hey, I see where the ACL start. Huh, hang on, let me look at that again. It starts and it stops. It doesn't connect. That's a torn ACL. That's how they find these things. On top of that, look at the gap in the joint space. Right? That's a factor too. But again, I'm not going to make you pull out a torn ACL on an MRI, but I show that to you because when you learn your physical exam findings, there are physical exam special tests that you can do where you're going to be like, I think you have a torn ACL. So now, you're going to get the x-ray because we always do an x-ray on musculoskeletal stuff, but they need an MRI because that is what's going to show me whether or not the ACL is torn, right? Soft tissue. So understanding the injury you're concerned about and what is the best imaging to be able to validate that potential diagnosis, initial versus best. It's just a really cool picture. Right? You don't have to read this, but you can see the different parts of the brain, right? The cerebellum, the cerebellum. You can see all that. You see the spinal cord coming down the CSF. I just think MRI is a really interesting, unique modality, right? But you're not going to dictate this. You're not going to read this. Radiologists report for MRIs all day long. Now, if you're really interested in learning to do that when you do your radiology rotation or your ortho rotation, get in there. Because if any of you go into the ortho fellowship, how many are interested right now in thinking ortho when they get out eventually, right? Good. You will learn to read MRIs when you go to the ortho fellowship, right? You don't need to as a standard outpatient family practice PA, but as an ortho fellow, absolutely. You'll need to learn how to read those because you're basing your surgical plan off of those MRI findings. So, we'll get into that in a second, but pros, no ionizing radiation, right? That's the pro, no radiation for this one. Cross-sectional imaging, expanded grayscale, data manipulation, same pros as CT. The extra pro is that there's no ionizing radiation. Cons, expensive, very expensive. We're talking $3 to $5 grand per MRI at a minimum. Very expensive. It's not as readily available. Not every clinic has MRIs. The two places I worked at did not have, before I came here, in the military, did not have MRI scanners. So if I wanted it, I had to send it out in the community. So they're not readily available, and I would be stunned if any of you have an MRI scanner in any of your deployed settings. You just don't need it, right? And the reason for that is there's no such thing as an emergent MRI, right? The lowest scan is 45 minutes. There is no situation out there where you're like, if they don't get this MRI now, they're going to die. Because the scan's gonna take 45 minutes. So there's no such thing as an emergent MRI. All MRIs get scheduled out. Very rarely are you calling somebody in if you're in the ER or something like that because a patient needs an MRI to make a medicine plan. No ferromagnetic objects. It's magnets. What's one of the most common ferromagnetic objects we would be concerned about in our patient population? PFC, but those can be removed, so make sure that. Say again? Replacements. Let's think more on active duty population. Shrapnel. What happens if they have shrapnel and they go into an MRI scanner? How many patients know all the shrapnel they have? Probably not. That's why with every MRI, they get an X-ray first. If you're doing an MRI of the shoulder, you better order an X-ray for that shoulder as well. Because you need to verify that there is no shrapnel or anything that's not supposed to be there in that shoulder. On top of that, what if the abnormality is bony anyways? The MRI is not going to do a great job on showing that except for like certain special cases. So the X-ray is the standard anyways. So always order an X-ray for a patient who's getting an MRI on that same body part if they haven't had an X-ray done within the last 2 weeks to a month, right? If they started off with an X-ray and then they got another X-ray and then they're coming in and things aren't better, you're gonna order an MRI, well they just had X-rays. You don't have to do another one prior to the MRI. But you need a recent-ish, I would say within the last 30 to 45 days or so of an X-ray before you get an MRI to make sure you're not missing something that could be in there that the patient doesn't know about and it gets ripped out. Okay. It's a stationary system. That's a con. It's also, sorry, thank you.
Going back to the magnetic.
Yeah.
It can be turned off if electromagnets.
Say it again?
Can it be turned off in emergencies? Like say someone with metal enters a room.
Oh, okay, so good question, right? So it's constantly going, but it's not constantly going, right? So they do have an emergency stop button, like if a patient starts screaming or whatever. But if you can walk into the room and have like, if I have this on me and I walk into the room and the scan is not going on, it's not going to affect the scanner necessarily. Because you gotta think the patient's beds have metal on them and things along those lines. So it's constantly going, but like it's more like a fridge magnet level when you're loading stuff. But once the patient is on there and they kick the machine on, that's when the high power magnets hit. So it's safe for you and I to walk in with keys in our pocket or anything like that as long as we're out of the room before they start the actual scan.
How long does it take to emergency shut it off in an emergency?
Well, so the magnets shut down immediately. Yeah, they have a button on the outside of their console where they just hit it and it just shuts it down immediately. Damage is probably already done because it doesn't take much once these magnets kind of kick on. So they have a huge questionnaire too that they ask all the patients who are getting an MRI. That's like, hey, do you have any piercings that are not removable? Do you have, a pacemaker? Is it safe? And most pacemakers nowadays are MRI compatible, and the patients have a card for that, right? Asking, do you have hip replacements? Again, nowadays most of them are titanium when they do them, so they are able to go into MRI scanners. And so a lot of this stuff is already going to be safe, but they ask the patient all these questions and do a pretty thorough screening before they even do the scan. Yeah, good question. Yeah.
So I had a guy code on me in the ER in the MRI. Even though we shut it off, I can still feel the pull.
Yeah.
So it was still pulling me, but we had to get him out.
You gotta get them out, yeah. So it shuts off the high power stuff, right? So it's safer to go in there, but you're right, like I said, they're always going. These machines, when they're on, there's always some type of magnetic field. So, cool. slow. Another con, right? 45 minutes to 2 hours. And here's the kicker. They do multiple things, right? See, they can be laying in there for like 30 minutes and then they like fell asleep and they twitched and then jacked up the imaging. And then you hear, ma'am, we're gonna have to restart that. I need you to hold still. You just added another 20 minutes onto your MRI just because they fell asleep and twitched. Happened. It's me. Sorry. My MRI report was like 10 o'clock at night. Like, it was ridiculous. I was tired. So, alright, so those are the cons. So what do we use it for, right? Neurological imaging, soft tissue around the joints, right? Maybe some masses, spinal cord pathology, so all these dark blues, right? Pay attention to that line. Female pelvic organs. Yes, we can use MRI for that, but it is technically second line. Ultrasound is first line. When we talk about ultrasound, you're going to see that. I have to put this on here because MRI is a modality that can be used for female pelvic organs, but it is not your first line treatment. Or your first line imaging. Ultrasound is your first line imaging. Again, all studies patients are lying down and you have prolonged periods of immobilization, 30 to 45 minutes. 30 is being generous. I would consider 45 plus. MRI has its own contrast. Gadolinium. Gadolinium is the contrast for MRIs. So what this one is showing you is the difference between a brain MRI with no contrast and the tumor we found after we added the gadolinium contrast. Okay? So not iodine based, not barium, gadolinium for MRIs. The risks of the gadolinium contrast, fairly similar to the IV contrast for CTs, but much less likely. It does not happen very often. High risk if they have liver, heart, or kidney disease, just like the CTs, and if they're pregnant, right? Do not ever give contrast to a pregnant woman, except in very specific scenarios, which we will talk about in block 2. Right? If you follow it, you'll get to that algorithm to follow through, like I don't have a choice. But you should not, if it's a study that needs contrast in somebody who's pregnant, you should be rethinking whether or not they truly need that contrast. So, no pregnancy, no kidney disease, right? Sure, nephrogenic systemic fibrosis, don't ever get MRI contrast. I'm not a factoid guy, right? You'll learn about that in neuro, they'll talk more about it, but it is one of the conditions that you should not give the gadolinium to. And then avoid repeat exposure. That's really for any patient, right? Because of how taxing the contrast is on the kidneys for either one. If you just got a CT contrast 2 days ago, let's say they did one and they did one for the abdomen, and then you're like, well, I want to look at the chest. They didn't do the chest, and you're going to get another one. Try to avoid that, especially if they just had one. Same concept of just taxing the kidneys over and over and over again. You're asking for disaster. But the biggest thing for this one, again, gadolinium, liver, heart, kidney disease, and pregnancy are your high risk. Another picture just kind of showing you the intact labrum versus the torn labrum. If you're like, I can't see that, that's fine. I'm not going to pull this out and ask you to diagnose the torn labrum. Okay? But here's where the labrum's at. It comes all the way across. It's intact where it's supposed to be. And then it's torn up in here, and then you have extra inflammation up top. That's what it's showing you. So labrum all intact. You got the fluid and capsule around here. Everything looks happy and good. I don't have any major inflammation or issues. Here I got this black line that comes up and comes down there, so it's torn labrum. And then this is all inflammation from the torn labrum. You're not going to have to dictate that or pull that out on an image. But if it's a patient where you have concerns for a torn labrum, which we'll get to when we get to the shoulder stuff, you need to know that an MRI is what you want to order in order to evaluate that torn labrum as the study of choice. All right, what study's on the left? It's an MRI on the left. What's on the right? CT. What type of slice? Sagittal for both. Good. Good. Benefits of using MRI, we just talked about it, non-ionizing radiation. Drawbacks are slow, we just had that whole slide, right? That's for you guys. Uses we just talked about. These things happen. Forgot to pull the patient bed. Right, the patient was not in there. The patient was not in there. What this was a patient that they ended up transferring to a wheelchair afterwards. And they finished kind of doing stuff and they completely forgot the bed was in there. This is like a $3 million mistake.
Is that that's gonna damage the machine like
Oh,
that?
yeah.
Is it pretty non-durable on the outside of it and everything?
Yeah, this is just plastic. All this white here, this is just plastic. So that damaged the machine. That's a $3 million mistake. Luckily one you guys won't make because you're not the one running the scanner. But I feel bad for that rad tech. That is not good. Questions on that stuff? Sir?
So going back to the contrast for MRI,
Yes.
are there any contraindications for using that unique contrast with MRI? Like we talked about if there's a potential leak in like the GI tract, would you want to use iodine base? It's always the
No, so because keep in mind, right, when you're talking about the potential leak in the GI tract, this MRI contrast, I think let's see, is that on the slide? If not, I'll say it. Yeah, it's IV or oral, so no, it is water soluble.
okay.
It is water soluble, thanks for asking. I haven't seen very many cases or studies where we actually give the oral gadolinium for an MRI. It technically can be, but 98% of the time, it's gonna be an IV contrast. Yeah, thanks for asking. Any other questions? All right, I'm sorry, I love you guys, but I'm gonna briefly jump into the next one. Yeah, sure. All right. San Antonio on Thanksgiving weekend. This stuff is gnarly. This is some of the stuff some of y'all will see when you go to your phase twos. Like not that, but the patients coming in from that. So where do you start when these patients show up at the emergency department? So EFAST is an option, yes. We're gonna talk about EFAST a little bit in this section, good. But you're starting with that and x-rays. Because x-rays are quick, they can do them bedside, right? You double check some of those things, what we're seeing here, and we'll go over block 2. We got a pneumothorax here, and we got a fractured pelvis there. Pneumothorax and fractured pelvis. Don't get hung up on the pneumothorax, it's a block 2 thing, but that is something that's on there. And then pelvis, I mean, when we learn how to kind of follow the cortex and everything, we're gonna see all these fractures down here in the pelvis, down in this area here. So yes, x-ray, patient must be stable-ish before going to CT. Alright, if they are clearly unstable, you do not send them. That's where that EFAST comes in, which we'll talk about. So here, what are we talking about here? Ultrasound, nuclear medicine, maybe a newer modality or two. I think I took most of those out because they were not value added or testable, so why waste your time with them? And then ordering studies, right? We will not get into all this today. Ultrasound. Vocab. So we had radio-opaque and radiolucid for everything so far. Now we have hyperechoic and hypoechoic. Because we have our transducer, which is what's used for the ultrasound. We will learn about posterior acoustic shadowing enhancement as we go through the lecture. Ultrasound is a little bit different, okay? What's going on here? Twins. Possible 2 uteruses, maybe? Right? But yes, these are not aliens, these are babies. We use ultrasound on babies. Alright? When did it start? It started in the 20s and the 40s. Really, ultimately, it was the Navy that we got this from. Any Navy in here? No, it's like the one good thing the Navy gave us. I say this with Navy in there as well. So it's not just because there's no Navy in here, right? They've been dealing with ultrasound for years before we used it for medical imaging. Doing what? Radar, sonography in the water, right? That's what they were doing. And then they finally developed, like, hey, let's try this stuff for abdominal imaging and see how it works. And we found out it works. And so there were multiple improvements over the years. Doppler, and in the 80s, Japan started doing 3D imaging. Now we do it here. They were ahead of the curve on that. So lots of advancements in ultrasound, but all starting with the Navy. Right? Here's what the machine looks like. Those things in the upper left are your transducers, different kinds for different parts. Don't worry about that right now. You will learn that more in your senior semester when you actually get the hands-on EFAST on each other, which is super awesome. When I came through, we didn't do that. Partially because ultrasound wasn't as widely used bedside as it is now. EFAST was still kind of growing in that aspect, and now it's used everywhere. So super cool that you guys get to do that. The gel is the key thing, right? So with all the other imaging, they can do more radiation, less radiation, whatever the case may be. With this, it's all about the gel, okay? So gel is what you put on the patient's body in between the transducer and there. And when you're doing your scans, if you're not having a good picture, get yourself some more gel. And for those of you that have not seen this, please Google Saturday Night Live, Cowbell, Christopher Walken. You will thank me later. You will thank me later. It was one of the funniest skits SNL has ever done. But use more gel. Often why do I say this? When you guys are doing your ultrasound and you're not getting the picture and you can't see it that well, what do you normally do as novices? Push harder. Don't push harder. Push harder does nothing. The odds are you just need more gel. Pushing harder is not going to get you a better image on that ultrasound. You're going to learn on the machine how to change the depth of what you're looking at, but pushing harder does not help. You're just going to hurt the patient. All right, but here are some images that get produced via ultrasound. So how does ultrasound work? Ultrasound is sound waves. Think bats, echolocation, right? They send it out, it bounces off of things, and it returns back to them. And that's how bats know where to see, and they don't run face first into a cave wall, right? Same concept with ultrasound. The transducer pushes sound waves into the body. It hits different structures, bounces back. It receives the bounce back based off of the energy, the speed, the amount of sound wave that's coming back to that transducer, and that's what creates the image in the picture. So what we have on number 1 is baby, okay? What we have on number 2 is the heart. And what's interesting here, you're like, whoa, the ventricles are up towards the top, but I learned that the atria are at the top. It's all based off of where your transducer's at, and that's why I say this is user dependent. So most of your cardiac ultrasounds are subxiphoid. They go up underneath, which means the closest thing to your transducer is your ventricles, and your atria are farther away, which is why this looks flipped and upside down. It's not. It's just because that's where the transducer is at. So that's why I say it's very user dependent. Do you understand what you're looking at and where you're going? And this here is liver with a bunch of little masses in it. We'll get more into what you gotta look at for an ultrasound from there. YouTube video, if you wanna learn all about that sound stuff, like 2 or 3 minutes. And here's another slide that kinda tells you what I just said, right? The transducer is the sender, it sends out, gets bounced off the object, and gets pushed back, okay? Higher frequencies will provide higher resolution, but less penetration. So higher frequencies, it looks better, but it doesn't go as deep. Lower frequencies, it doesn't look as nice, but you can get deeper with it, okay? And you'll play with those knobs in your EFAST depending on how far you gotta go and how big the patient is. Most everybody here is pretty healthy, so you'll probably all have the same settings. But when you're out there doing your EFAST exam, I promise you, your frequencies that you're gonna set on your knob are gonna be much different for the 150-pound trauma patient compared to the 425-pound trauma patient, because you have a lot more tissue to get through, right? So high reflection, more solid structures are going to be brighter white. Lower amount of reflection, less solid structures are going to be more darker. Okay? So you can see, right, this is heart, left ventricle, left atrium, mitral valve, aortic valve. Fluid on ultrasound, now here's where we don't want to get tripped up. Fluid on ultrasound is what color? Black. Fluid on X-ray and CT is grayish. Air is black on X-ray and CT. Fluid is black on ultrasound. Why? Because sound waves go through water pretty well. It doesn't really reflect much of it. So when I'm going through the fluid, it's just there's no reflection of that. So there's no data for the transducer to read to say there's something there. Okay, but when I get to pericardium, cardiac wall, right, that's actual tissue, it's bouncing back on that. So fluid is black on ultrasound. Also, what we're seeing here is an ultrasound of an extremity. So you have the skin up top, you got all the subcutaneous tissue right here, subcutaneous tissue, muscle, see the striations, and the cortex of the bone. So you can see how you can still get layers. So this can be helpful for like draining a cyst or something that's sitting like right here in the subcutaneous tissue, because you can see it on the ultrasound, and you can put the needle right into it and drain it out. Good phase 2 procedure for you. But it's another thing that ultrasound can be used for. Okay. Posterior acoustic enhancement. We will go over that tomorrow. Because I don't want to go over that without going over the shadowing next, so that way you guys can put the two together. So we'll go over that tomorrow, so we'll stop there for today. What questions do you have? Alright, so far, we've covered the very basics of the history of some of those modalities, and all we've really touched on is recognizing which one you're looking at, and knowing how to kind of interpret the colors and kind of what you're doing, and what's black, what's gray, what's white, all of that, all these things. And then mainly the uses for them, the pros and cons of each one, and what are the primary generality uses of these, right? A lot of that history stuff is there because it's in the book and it's wrong. I'm gonna kind of go over that, telling you where it came from. I'm not testing on that, all right? So that's kind of the meat and potatoes of what we've talked about so far in these modalities. If you have questions on that, let me know. If you have questions on when would I order this for this particular abnormality or disease process or things like that, hold those burning questions, because we're going to get into it as we continue to go through this block and start looking at abnormalities, which will start with lecture 4, right? The slide deck 4, right? Other questions right now? All right, have a great day, guys. I'll see you out there for a few minutes.